Hello, welcome back everyone, and I hope every one of you is doing good. Okay, so let's start our class from where we left. Okay, and we completed till the ANP and the BNP, and today we will discuss the baroreceptor mechanism, and then we will discuss the autoregulation and the stalling forces, and then we jump into the pathology. Okay, so let's start our baroreceptors. So first we discuss the baroreceptors, then we will discuss the chemoreceptors. So baroreceptors. Receptors are what? They are a specialized receptor, I will say. They are the special receptor which actually senses what? They senses the pressure changes within the large blood vessels. Senses, they senses what? Senses the pressure changes. Senses the pressure changes within the large blood vessels. Senses the pressure changes within the large blood vessels. Okay, large blood vessels. Pressure changes mean, I mean to say pressure changes means decreased pressure or increased pressure. They are specialized for sensing these your pressure changes. So baroreceptors are located in there are two locations for baroreceptors in the blood vessels. So location wise, you see baroreceptor is located in the aortic arch. So it is located in the aortic arch. So aortic arch has a baroreceptor, okay? Aortic arch or simply arch of aorta. So suppose this is my arch of aorta. I'm drawing a picture for you. This is called the arch of aorta. So this is ascending aorta going on. And this is called the arch of aorta. Okay. So within the arch of aorta, this blue receptor, this is called the baroreceptor. This is called the baroreceptor. So this baroreceptor will send the signals. It will tell the pressure changes to the blood pressure central control. Can anybody tell me what is the location of blood pressure control center, where it is located? So this baroreceptor will suppose your blood pressure when your pressure in the aorta is actually 150 by 100. When the baroreceptor senses that the pressure is high, it will actually send this information to your blood pressure control center, and that blood pressure control center is located within the brain. Can anybody tell me in what portion of the brain the blood pressure control center is located? Suppose
Medulla.
very good. It's located in the medulla oblongata. Excellent. So this will be my brain. So this is actually my brain, which I'm drawing with the, I would say, the green color. My brain. And within the brain, I have the brain stem being shared. So this is my medulla oblongata sitting. Medulla oblongata. Okay. Please don't control
So,
the whiteboard. It's very difficult for me to write then. Okay. So otherwise, I will actually, do the restrictions. Put the restrictions. Look at this. So if
so
you,
doctor, is it in the Nicholas Solitarios, correct? Or
yeah,
is it
I'm coming to that. I'm coming to this. I'm coming to that. Okay. So let me first generalize it. Okay. So it's being located where? It's being located in the medulla oblongata. Okay. So medulla oblongata is there. I don't know someone do what. I cannot write on the whiteboard, to be honest. So it's being located on the medulla oblongata. All right. Mm-hmm. I don't know what went wrong. Hmm. What's happening? I have to create another whiteboard. Okay. I'm exiting this whiteboard and I have to change the policy. Do only host. Do not allow anyone. Do not allow anyone. Okay. That's perfect. Okay. That's perfect. Okay. So I was discussing about the baroreceptor. So I draw the picture of aortic arch, but I don't know what happened wrong. I was unable to. Consumers are hidden because more than 20 and join this. Okay. Okay. So this will be your aorta. Will be your ascending aorta. Okay. And this will be your, I will say, the arch of aorta. Okay. And this is arch of aorta being there. And the blue structure within the arch of aorta is called the aortic arch. It's aortic arch that's called baroreceptor. Baroreceptor is actually present. This is a baroreceptor. Now, suppose if your blood pressure is 150 by 100, by 100. So this is a job of the blood baroreceptor to send information to your medulla oblongata. So this will be my medulla oblongata, which I'm drawing here. Medulla oblongata. Okay, so it will send the efferent fibers. So these efferent fibers will go from baroreceptors to the medulla oblongata. So I'm drawing these efferent fibers with a blue color. This will be my efferent fiber, which will actually tell the blood pressure changes to your medulla oblongata. Okay, so these efferent fibers, what is the name of the nerve which carries the efferent fibers from the aortic arch baroreceptors to the medulla oblongata? That's called vagus nerve. Okay, so cranial nerve 10 is a vagus nerve. So when your medulla oblongata receives the information that blood pressure is 150 by 100. So what will the medulla oblongata do? The medulla oblongata will try to reduce the blood pressure because this is a high blood pressure. So medulla oblongata will actually try to decrease the blood pressure to 120 by 80, which is normal. So it will actually send some efferent fibers. It will send some efferent fibers, and it will send. So what there are two types of the efferent fibers which are leaving the medulla oblongata. So that I am drawing with the black color. So this will be my sympathetic efferent fibers. This will be my sympathetic. So two types of the efferent fibers leaves the medulla oblongata. Sympathetic fibers, okay, which are black one, and other is called your other color is actually called your pink color, which is called the parasympathetic fiber. These are my parasympathetic fibers. So these fibers leaves your medulla oblongata, parasympathetics. So when your blood pressure is high, what will the medulla oblongata do? The medulla oblongata will increase the parasympathetic stimulation of the heart. It will send so there will be more parasympathetic stimulation and decrease sympathetic stimulation. Because if I increase the parasympathetic stimulation to the heart, it will do what? It will decrease the heart rate, plus it is going to do what? It is going to increase the AV nodal delay time. Is it? So my AV nodal delay time is going to be increased. Okay. AV nodal delay time is going to be increased, so that will reduce my blood pressure. So you guys know that the equation of blood pressure is what? What is the equation of blood pressure? Can anybody tell me blood pressure is equals to what?
Cardiac output times total peripheral
Cardiac
resistance.
output times total peripheral resistance. So you
Yes,
guys
sir.
see, I reduce the cardiac output by increasing the parasympathetic stimulation to the heart. Now I also have to reduce the total peripheral resistance. And how I can reduce the total peripheral resistance? By decreasing the alpha 1 stimulation on the blood vessels. And the only way to decrease the alpha 1 stimulation on the blood vessel is to reduce the sympathetic tone to the blood vessels. So this will be the response against the high blood pressure. When your blood pressure is very high, what will happen? So these were vagus was what? Efferent fibers. Efferent. Okay. And two efferent leaves the medulla. Two efferent leaves the medulla. That is actually your sympathetic and the parasympathetic. These are called efferent ones. Okay. They are called efferents. So what is the response of baroreceptor against the high blood pressure? So when your blood pressure is very high, when your blood pressure is high, what will happen to the arterial stretch? The stretch of the arteries will increase, is it? It will have the more stretching of arteries. And when you get more stretching of arteries, what will happen? what will happen? The efferent firing rate will increase. It will lead to increase efferent firing rate. So whenever medulla oblongata receive more signals from the vagus nerve, it always thinks that the blood pressure is very high in the periphery. So what it will do, it will increase the parasympathetic stimulation to the heart and decrease sympathetic stimulation to your blood vessels. Okay. So this is the response against your high blood pressure. Did you guys understand the response against high blood pressure? Now we will discuss the response against the low blood pressure. When my blood pressure decreases, what is going to happen then? Okay. All right. So this was my blood pressure. Okay. Okay. This will be same efferent will be there. Okay. All right. So my response to the low blood pressure. So similar pathway will be there, but the pressure is low this time. So when your blood pressure is low, suppose when your blood pressure is directly 80 by 40. So when your blood pressure decreases, when your decreased blood pressure is there, what will happen to the arterial stretch? The stretch of the arteries will decrease, is it? And when your stretch of arteries will decrease, what will happen to the efferent firing rate? The efferent firing rate will will decrease, is it? Efferent
Yeah.
firing rate will decrease. And when your efferent firing rate decreases, medulla oblongata thinks that what does the medulla oblongata thinks? The medulla oblongata will thinks that the pressure is very low in the periphery. Is it? Pressure is low in the periphery, so let's increase the pressure. So what will the medulla oblongata do? Medulla oblongata will increase sympathetic efferents, sympathetic fiber. So you will have increased sympathetic stimulation to your blood vessels and the heart. So if you increase the sympathetic stimulation to the heart, can anybody tell me what will happen then? Yeah,
Yeah, the heart rate will go up.
very good. So it will have the increased beta 1 stimulation, is it? Increased beta 1 stimulation. So increased beta 1 stimulation means increased heart rate. Okay.
Increase contractility, increase intestinal.
Excellent, excellent, very good, excellent. Contractility will increase, very good. So if you increase the heart rate, if you increase the heart rate plus contractility, that means your cardiac output will increase. So you increase the one parameter of blood pressure. Now, what about the second parameter? If you increase the sympathetic stimulation, if you increase sympathetic stimulation of the blood vessels, so
Vasoconstriction.
what receptors will be stimulated? So increase blood vessels, so
Alpha 1. Alpha 1.
there will be increased alpha 1 stimulation. Excellent. Alpha 1. Alpha 1 stimulation will be increased. And when you increase alpha 1 stimulation, what will happen? You get the vasoconstriction.
Preload will also will be increased, correct, doctor?
Yeah, preload.
Systemic vascular resistance
Right,
will
you're right.
increase.
Preload will increase because you will also get venoconstriction. So preload,
Correct.
afterload both will increase. Is it? Preload and afterload both will increase. So this is the response against the low blood pressure and the high blood pressure. So this is very sensitive. These changes are very sensitive. Blood pressure change is very sensitive. So medulla oblongata will have to be very efficient. It's very efficient to control the blood pressure. Okay. So at the same time, medulla oblongata will reduce the parasympathetics, will reduce the parasympathetic stimulation to the heart. So when you reduce the parasympathetic stimulation to the heart, what will happen? Your heart rate will increase and your AV nodal delay time will what? It will decrease. Okay. So this is a response to your low blood pressure. So baroreceptors are located in there are two locations of baroreceptor. One is called aortic arch and other is called your other location of baroreceptor is called your carotid arteries. That's being located in your carotid artery. So in the carotid artery, where it is located, it's located at the bifurcation of the internal carotid artery. Okay, so at the bifurcation of the carotid artery, it's located. When your carotid artery divides into internal carotid and your external carotid is being located at this location. So can anybody tell me why? What's the reason why the baroreceptors are located in the carotid artery? What's the
Yeah,
reason?
because this is where the blood goes to the brain. You don't
Exactly.
want thing. You want to control things from the
Good
brain.
anticipation. Very good. This is where the blood goes to your brain. Okay. So this is actually, these are the two baroreceptors. All right. Any question regarding baroreceptor? And after baroreceptor, I will discuss the Cushing reflex, which is a component of the baroreceptor. So did you guys understand this baroreceptor mechanism of action, how they are actually working? Get it? Everything clear? Okay. Now we're going to discuss the Cushing reflex, which is a component of baroreceptor. That's the reason we are discussing here Cushing reflex. Cushing reflex. So Cushing reflex. So Cushing reflex is seen in those patients who have the head trauma, or Cushing reflex is a reflex which is seen when you have the increased intracranial pressure. When your intracranial pressure increase intracranial pressure, which is secondary to the trauma to the head or could be due to the brain tumors. So when you get increased intracranial pressure, what will happen to your cerebral blood flow? Your cerebral blood flow will increase or decrease when I get the increased intracranial pressure. Yep, anyone?
Decreases.
It will decrease because the pressure puts pressure on the arteries that
Very
is supplying.
excellent, good job. So when your intracranial pressure increases, it will lead toward collapse of the cerebral arteries. Collapse of cerebral arteries. So when you collapse the cerebral arteries, what will happen? It decreases cerebral blood flow. And when you decrease the cerebral blood flow, suppose your cerebrum is receiving less amount of the blood, the bose of the body is receiving less amount of the blood. So what will the bose do? Bose will do, excuse me, sorry. So decreased cerebral blood flow is there. So what will the bose do? Bose will do everything to increase its blood flow, is it? So what will the brain do? Brain will do what? Brain will try to increase the pressure within cerebral artery. So brain will do what? Brain will actually try to increase the pressure in the cerebral arteries so that pressure can counteract against the increased intracranial pressure. Okay. So the only way to increase the pressure in the cerebral artery is to do what? Is to cause vasoconstriction of cerebral arteries. Is it? So when you do vasoconstriction of cerebral arteries, the cerebral artery pressure will increase. It will be more than the pressure in the intracranium. So vasoconstriction of your cerebral arteries will happen. Okay. And when you do vasoconstriction of cerebral arteries, what will happen? That will increase pressure in cerebral artery. So this increased pressure in the cerebral artery is greater than the pressure in the intracranium. So right, so this pressure in the cerebral artery will be greater than the pressure in the intracranial cavity. So your cerebral artery will open. And you will get the more pressure. Now, can anybody tell me how did I achieve the vasoconstriction of cerebral artery? The way I achieve the vasoconstriction of cerebral artery by increasing sympathetic stimulation of the body. Increases sympathetic. So I do what? I increase the sympathetic stimulation. Okay. So I increase the sympathetic stimulation of body. So if I increase the sympathetic stimulation within the body, it will not only cause vasoconstriction of cerebral arteries, but it will also cause the vasoconstriction of your aorta as well, is it? You will also get vasoconstriction in the aorta, is it? Vasoconstriction in the aorta. And if I get vasoconstriction of the aorta, what will happen to the pressure of the aorta? Can anybody tell me?
Go up.
Will
Your
go
blood
up.
pressure go up.
Excellent. Blood pressure will go up in the aorta. And if your blood pressure goes up in the aorta, you guys know that within the aorta, the baroreceptor is located, is it? Which is very sensible to the pressure changes. So it will lead to stimulation of the baroreceptor, is it? Stimulation of baroreceptors. Okay, you get stimulation of baroreceptors. And when my stimulation of baroreceptor is there, what will happen to the firing rate of the baroreceptors, efferent fibers? It will increase firing rate, is it?
Correct.
And this increased efferent firing rate will be going to the medulla. So what will the medulla do? Medulla will try to decrease the blood pressure by increasing parasympathetic stimulation to the heart. And when it increases parasympathetic stimulation to the heart, your heart rate will drop, which is a second component of the Cushing reflex. So you guys see in the Cushing reflex, what is the trigger of the Cushing reflex? Just start from the trigger, raise intracranial pressure. So when you get raised intracranial pressure, it will lead to what? Increased blood pressure. So first component of the Cushing reflex was what? Increased blood pressure, or I would say hypertension. Hypertension. Hypertension was due to increased sympathetic stimulation. And second component of Cushing reflex is called bradycardia, reduced heart rate. And why did I get the bradycardia? Because of your baroreceptor.
Parasympathetic.
This is where the baroreceptor plays a role. That is why baroreceptors are the component of the Cushing reflex. So that is the reason I am discussing the Cushing reflex here. Otherwise, Cushing reflex is the topic of the neurology. Okay, so this will be your decreased heart rate will be there. And the third component of the Cushing reflex is actually what? Can anybody tell me what's the third component?
Respiratory depression.
Excellent. Can anybody tell me why there's a respiratory depression? What's the reason? Yep.
Because parasympathetic.
Medulla is affected.
Yep. Very good. Somebody was saying medulla, because medicine without evidence is testless.
Respiratory center is located in the medulla.
Excellent, excellent. You get the herniation of the respiratory center in the medulla oblongata, because raised intracranial pressure will interfere with the function of the respiratory center. Very good, excellent. So these are the three components of Cushing reflex. Did you guys understand this Cushing reflex? It's a very easy reflex being there. Okay, not a difficult one. All right, now I'm going to jump into the chemoreceptors. Okay, so that was all about your baroreceptors. Now let's discuss the chemoreceptors. Chemoreceptor, as the name suggests, they are going to sense the changes in the blood chemistry. They are going to sense the changes in the blood chemistry. That's called chemoreceptor. Okay, chemoreceptor, as the name suggests. So what's the function of chemoreceptor? Chemoreceptor function is actually what? Senses changes in the blood chemistry. Blood chemistry, I mean to say, they will be very sensible to the changes like your blood carbon dioxide level, PCO2, and blood pH. They will be very sensible to the changes in the blood pH. And last, they will be very sensible to the blood oxygen level. Okay, so that's the role of the chemoreceptors. Now, chemoreceptors are of the two types. One is called peripheral chemoreceptor and is called central chemoreceptors. So depending on the location, we have the two types of the chemoreceptors being there. So we have the peripheral chemoreceptor. Peripheral chemoreceptors. So peripheral chemoreceptors are located where? They're again located where? They're again located in your aorta and the aorta, arch of aorta and the carotid arteries. So the chemoreceptor which is located within the aorta, it is called aortic body. Is it? It's called aortic body. Aortic body. Aortic body. And the chemoreceptor which is located within the carotid artery, that will be called carotid body. Carotid body. Okay. Now these aortic bodies are stimulated. They are very sensible. They are very sensible to the changes in the blood carbon dioxide level. So whenever your blood carbon dioxide level goes up, when your PCO2 goes up, the aortic body will sense its PCO2 go up. So similarly, it will send, this PCO2 have to do with the respiratory center. So there will be efferent fibers, similar efferent fibers will be there, and these efferent fibers are called vagus nerve. So vagus nerve will send the information to what region of the brain? Do you guys know in what region of the brain my respiratory center is located? It's again medulla oblongata. So it will send the information to your medulla oblongata about increased PCO2. Now medulla oblongata will receive what? Medulla oblongata receive the signals, increase PCO2. So medulla oblongata is going to send the efferents. So what will the medulla oblongata do? Medulla oblongata will try to increase the respiratory rate to remove the PCO2 out of the body. Can anybody tell me how medulla oblongata will increase the respiratory rate? Yep. What's the mechanism? Yep.
Sympathetic stimulation.
Hyperventilation.
Very good. Excellent iPhone. Hyperventilation. So it will stimulate the contraction of what muscle? Very good. It will lead to hyperventilation.
Intercostal muscles and diaphragmatic and abdominal muscles.
Diaphragm.
Diaphragm.
The contraction of diaphragm. Okay. Increase the contraction of diaphragm. And how they can increase the contraction of diaphragm? They have to increase the stimulation of the phrenic nerve. Is it? Increased contraction of diaphragm. And when you get increased contraction of diaphragm, what will happen? All the carbon dioxide will be removed out of the body. Okay. So this is how the medulla oblongata is working, by increasing the phrenic stimulation. All right. So that will be your response against your PCO2. Similarly, they are very sensible to the changes in the blood pH. So when your blood pH decreases, it means you have the what? Acidosis. Acidosis means, so you guys know what's the compensation for acidosis. Suppose when pH is decreased, my pH decreases, medulla oblongata will receive the signals of decreased pH by vagus nerve. So what will the medulla oblongata do? Decreased pH means you have the acidosis. And what's the response against acidosis? You will get what? Respiratory alkalosis. And how will you get respiratory alkalosis? By removing the carbon dioxide out of the body. Again, in a similar way, they will do the hyperventilation. Okay? Hyperventilation to bring back the pH back to the normal. Okay? Which is called respiratory alkalosis. All right. So this will be the the response of aortic body against these changes. Now, carotid bodies, also are very sensible to changes in the carbon dioxide level. But the difference is what? What's the difference between the carotid body and the aortic arch? Or sorry, aortic body. The efferent fibers from the aortic bodies are carried by vagus nerve. Here, the efferent fibers will be carried by glossopharyngeal nerve. Cranial nerve 9 is going to carry them. Cranial nerve 9. So cranial nerve 9 is going to carry the efferent fibers from carotid bodies to your medulla oblongata. Okay, and once they carry to the medulla oblongata is going to do again hyperventilation. So difference mechanism of your hyperventilation is same. The only difference is of what? Only difference is of your, all right, only difference is of the efferent fibers. Only difference is of the efferent fibers. So that's all about your peripheral chemoreceptors. Chemoreceptors are very simple. Now we are going to discuss the central chemoreceptor. Central chemoreceptor. So within the brain, we also have the chemoreceptors being present. They are called the central chemoreceptors. Now, central chemoreceptors are different from peripheral chemoreceptor in a way, in an aspect that central chemoreceptor does not respond to the blood oxygen level. They does not respond. So they actually respond to what? They respond to changes in the carbon dioxide, respond to the changes of PCO2 and pH of the blood. They does not respond to the oxygen changes. They does not respond. They are specialized for changes in the blood carbon dioxide levels. Okay. So when your carbon dioxide level increases within the brain, when your carbon dioxide level increases within your brain, what will happen? These will be sensed by your chemoreceptors, which are located in the area posterior. You guys remember area posterior, which lacks the blood-brain barrier? Area posterior does not have the blood-brain barrier, so because they will actually senses the changes in the blood chemistry. So these receptors are located in the area posterior, where they will actually sense the carbon dioxide level. And once your carbon dioxide level is increased in the brain, if it is increased in the brain, what is the effect of the carbon dioxide on the blood flow? It will increase the brain blood flow, decrease the brain flow. Yep.
Increase.
Very good. It is going to increase the
Vasodilation.
Yes, very good. It leads to vasodilation. Excellent. And why it leads to vasodilation? Because you know your carbon dioxide will only increase when there's a decreased blood flow to the brain. So you have to compensate. These receptors are working to compensate, to actually set back the hemostasis to the physiologic condition. Okay. So vasodilation will happen, and that vasodilation will increase the blood flow. So when you increase the blood flow, the oxygen will be increased and the carbon dioxide will be decreased. Okay. Similarly, the pH change will have the similar mechanism being there. All right. So that's actually there. Now, if your carbon dioxide level is chronically increased in the blood, it will lead to chronic stimulation of central chemoreceptors. So when you chronically stimulate the central chemoreceptor, what will be the outcome? Can anybody tell me? When you do chronic stimulation of central chemoreceptor, chronic stimulation.
They become less responsive to increase in carbon dioxide changes.
Very good. Excellent. Excellent. So the chronic stimulation will do what? It will do what? It will actually lead to reduce response to PCO2. And you guys know in what group of the patients there's a chronically elevated carbon dioxide level, that's called COPD.
COPD.
So very important to know the respiratory rate of the COPD patient does not depend upon your blood carbon dioxide level. It depends upon the respiratory drive depends upon the blood oxygen level. So if it is blood oxygen level, it means the respiration of the COPD patient will depend upon the peripheral chemoreceptor. That will not be depending on the central chemoreceptor. Although central chemoreceptor or changes in the carbon dioxide level is a more efficient way of the increasing respiratory rate, but oxygen level is not an efficient way. It will take some time. So what happens? So that is the reason, you give COPD patient less oxygen than their required amount. Suppose if the requirement of COPD patient is 4 liters, if 4 liters of oxygen, you will put the COPD patient at the 2 liters. So you always give them the decreased oxygen than their demand. Decreased oxygen is given to the COPD patient, because when you give decreased oxygen, that will keep stimulating your peripheral chemoreceptor. All right, so that's all about your chemoreceptors and the baroreceptors. Okay, anybody have any question regarding chemo and the baroreceptors?
Yes, sir. When you mentioned the carotid body and the sinus, so that one it's a baroreceptors, correct?
Now, carotid body is actually your chemoreceptor. Carotid sinus is actually baroreceptor. Okay.
Baroreceptor. Oh, thank
Okay,
you, sir.
no worries. And then both of them send the signals to the medulla through cranial nerve 9, glossopharyngeal nerve, because glossopharyngeal nerve is very near to them. Okay, glossopharyngeal nerve
Another
does.
question. For the baroreceptor, does both of them good at low pressure, high pressure, or some of them are good in high pressure, some of them good at low pressure?
Both high pressure, low. They changes in the blood pressure means decreased blood pressure or increased blood pressure. Okay. So that's actually all about your baroreceptors and the chemo. And let's discuss now the normal resting cardiac pressure. Normal resting cardiac pressures. So normal resting cardiac pressure, I would say not an important one, but you should remember what is actually pulmonary capillary wedge pressure. Normal resting cardiac pressure. Normal resting cardiac pressure is exactly there. So normal resting cardiac pressure. So I mean to say, what will be the pressure in the right atrium? The pressure in the right atrium will be less than 5 mm, because It's a point which receives the blood from IVC and SVC. So it means the right atrial pressure is less than 5. So what will be the pressure in the IVC? It will be greater than 5 or less than 5?
Greater than 5.
Excellent. It should be greater than 5 to maintain the flow. Otherwise, the blood will not go into the right atrium. Okay. So that will be less than 5 being there. Similarly, when I go to the right ventricle, in the right ventricle, the diastolic blood pressure, I would say diastolic, not systolic. The diastolic blood pressure should be less than 5. Why? Because to maintain the blood flow, from blood should go from right atrium to right ventricle, the pressure should be less than 5. So diastolic blood pressure in the right ventricle is actually less than 5. Okay, it's actually less than 5. Now, what will be my pressure in the pulmonary artery? The pressure in the pulmonary artery should be what? What should be my pressure in the pulmonary artery? Yep.
Low.
It should be what? Yep.
A little bit more than 5.
Yeah, exactly. So it's going to be pressure in the pulmonary artery because you want to maintain the blood flow. But here you see right ventricular systolic blood pressure is more. Right ventricular systolic blood pressure is actually 25 and the diastolic blood pressure is less than 5. Okay. So you mean here in the pulmonary artery, the systolic blood pressure should be equals to 25 and the diastolic blood pressure will be equals to almost 8. Why it is 8? Because it have to send the blood to the pulmonary artery. Is it pulmonary vein? Sorry, pulmonary vein. So pulmonary vein is going to receive the blood. So pulmonary vein will have the pressure. The pressure in the pulmonary vein is called pulmonary capillary wedge pressure. This is important. Pulmonary capillary wedge pressure is there, and that is actually we have the mean pressure being there. That's actually 4 to 12. It's between 4 to 12 is a pulmonary capillary wedge pressure. Now pressure in the pulmonary vein is equals to the pressure in the left atrium. Okay, so it will be the left. It is indicator of left atrial blood pressure. Left atrial pressure being there. So left atrial pressure will always be less than 12. It will be always less than 12. Okay, so we always measure the pulmonary capillary wedge pressure. Why do we measure the pulmonary capillary wedge pressure? To measure the pressure in the left atrium. Okay, so normally the left atrial pressure should be less than 12. Why it should be less than 12? Because pulmonary capillary wedge pressure is 4 to 12. So in order to maintain the blood flow from pulmonary vein to left atrium, the left atrial pressure should be less than 12. All right, so what will be the pressure in the left ventricle? Diastolic. I'm asking about the diastolic. If left atrial pressure is less than 12, what will be my pressure in the left ventricle? It should be less than 12, is it? Diastolic should be less than 12 to maintain the blood flow, whereas systolic is actually equals to 120. Okay, so that is actually the pressure changes being there. Now we are more interested in the pulmonary capillary wedge pressure. So pulmonary capillary wedge pressure is actually what? Pulmonary capillary wedge pressure is an indicator of your left atrial diastolic pressure and left ventricular diastolic pressure. Okay, so what will be the pressure? The pressure in the pulmonary, whatever pressure is present in the pulmonary vein, it will be the diastolic blood pressure of your left ventricle as well as your left atrium in all cases. Can anybody tell me what is the name of the procedure which we do to measure the pulmonary artery or pulmonary vein pressure?
Swan's catheter.
Swan's
Central vein.
Gaines catheter. Yes, Swan's Gaines catheter we use to measure the pulmonary capillary wedge pressure, and the pulmonary capillary wedge pressure is always equals to, I'm writing it again. Pulmonary capillary wedge pressure is always equals to left atrial pressure, which is equals to your left ventricular diastolic pressure. Left ventricular diastolic pressure. And there's a one disease in which what happens, there's a one disease, your pulmonary capillary wedge pressure is actually what? It is actually greater than, I would say it's greater than the left ventricular diastolic pressure. Can anybody tell me what's the name of that disease in which your
Pulmonary hypertension.
no
Mitral stenosis.
Mitral stenosis, excellent. Remember pulmonary capillary, put pulmonary capillary wedge pressure as the left atrial pressure. Okay, so why we are measuring the, what's the reason why we are measuring the pulmonary capillary wedge pressure? Because we are interested in the left ventricle. We are not interested in the left atrium. Okay, so in the mitral stenosis, it's going to be greater than the left ventricular diastolic pressure. All right, so that is actually about normal cardiac resting pressures. And what is the takeaway point for there? You have to actually understand the pressure changes. If the blood wants to go from one channel to other channel, if the blood wants to go from point A to point B, the point A pressure should be higher than the point B pressure. That's a takeaway point from this lecture. Okay, now we discuss the auto-regulation. What does mean by auto-regulation? Auto-regulation means how the blood pressure, how the blood flow to the different organs remains same throughout the changes in the perfusion pressure. So when you actually changes the perfusion pressure, still the blood flow to the organs remains same. That is called auto-regulation. So we are going to discuss that auto-regulation. Auto-regulation means how organs or how the viscera control their own blood flow when they have the wide range of the pressure changes. So suppose I'm going to take the example of the brain. That's very important to know. So when I have the reduced blood flow to the brain, when I get the reduced blood flow to the brain, what will happen in the brain? The carbon dioxide level will go up, is it? And when your carbon dioxide level goes up, it will do what? It will lead to vasodilation. And when you get vasodilation, you get what? Increased blood flow, is it? So this is called the autoregulation. Autoregulation means how the organ is controlling its own blood flow under the wide range of the perfusion pressures. Okay. Now similarly, take the example of your muscle, skeletal muscles. So when my skeletal muscle have the reduced blood flow, when my skeletal muscle is having the reduced blood flow, what will happen? What material is going to be produced? So when they have the reduced blood flow, they will have what? Increased carbon dioxide, is it? And they will have the increased H plus ions, is it? And what else they are going to have? They have the increased lactate, is it? Because they will shift to the anaerobic glycolysis. Lactate will be increased. So these increased lactate, increased H plus, increased carbon dioxide, and increased adenosine as well. Can anybody tell me why the adenosine increases?
Because ATP is consumed.
Very good, excellent, good job. You're thinking. Now you're on the track, is it? You're thinking. Very good. I appreciate that. Today you are in the good rhythm. Okay. All right. So because ATP is actually consumed, so adenosine will be increased. So when you increase these markers within the muscle, they are the local vasodilation. They will lead to the vasodilation of the muscle blood vessels. Is it? And you get what? You get increased blood flow to the muscle. So this is actually the mechanism I'm telling you. So what is happening here in every tissue? In every tissue, hypoxia causes vasodilation. Look at this. Whenever I get hypoxia, I will get what? Vasodilation in the brain, in the muscle, in the skin. Similar thing will happen in the skin, and similar things are going to happen in the kidney. So what is the general rule? General rule is actually what? Hypoxia will cause what? Hypoxia will cause vasodilation in every tissue of the body except one tissue.
Lung.
Yes, reason will cause vasodilation in every.
Because in lungs we get oxygenation of the blood.
Yeah, but tell me a proper reason. Your colleagues are waiting for your proper reason. Will cause vasodilation in every tissue except lungs. Except lungs.
If there is a decreased oxygen in the lungs, there will be decreased oxygenation of the blood, and we want decrease in the VQ mismatch. So we get more oxygenation of the blood.
Excellent.
So that's why it causes vasoconstriction in those areas where there is hypoxia to get the blood in those areas where there is more oxygenation. So we get
Very
more
good, very good.
oxygenated
Good
blood.
job, good job, good job, good job. Very good. You tried and your answer is correct. So what is the reason? You see, what is the purpose? Why I'm sending why I'm sending the blood to the lungs? To carry the oxygen, to carry the oxygen. So if the lungs have what? If the oxygen in the alveoli is low, if I have the low P A capital O2, and I'm sending the blood to this region. I'm sending the blood to this region. It means I'm wasting the perfusion, is it? So I'm resting the perfusion. So what will I do? I will close this pulmonary artery and will shunt the blood to the well ventilated area. Suppose this is my another area which is actually receiving the more oxygen. There's a lot of the oxygen being there. So I will actually send the blood. So this blood was coming here. I will actually block this artery, close this artery, and will shunt the blood to this region where I'm getting more oxygen. Okay. So I get the shunting here. Okay, so I don't want to waste the perfusion. My perfusion should be efficient. My perfusion should be efficient. So this is the reason I'm actually doing what vasoconstriction of the less ventilated alveoli. All right, so that's actually the reason here in the. All right, so that's how the auto regulation works within the organ when you're the wide range of the pressure being changed. Now in the kidney we have the myogenic reflex being there and tubuloglomerular that we will discuss in the renal hopefully. Now we are going to discuss the capillary fluid exchange. So how the exchange is actually taking place at the capillary level. Capillary fluid exchange. Suppose this is my capillary. So this is my arteries coming. This was my arterioles and this is my capillaries. Okay. My capillaries and this is my venule. Now this is my tissues. This is my tissue, which I'm drawing with a green color. And this is my interstitial space. The space which is actually present, this is called interstitial space or tissue space. Simply, I will say tissue space. Tissue space. Okay. Now, these are called the filtration. Filtration always takes place at the level of capillaries. So filtration is defined as what? What is the definition of filtration? Filtration is a movement of the fluid and solutes out of the capillaries into the tissue space. So when my blood reaches to the capillaries, okay, blood is actually within the capillaries, and this blood is containing the glucose. It is actually composed of glucose plus it is composed of what? Glucose is there. I would say the nutrients are there. Other are actually your proteins, amino acids are there. Amino acids are there. Fatty acids are there. And it is composed of the fluid as well. So what is the purpose of the filtration? The purpose of filtration is to send these nutrients to the tissue. So the nutrients will move out. This is called the filtration. Filtration is a movement of the fluid plus solutes into the tissue space. This is called filtration. Now there are certain forces which favor the filtration and there are certain forces which actually oppose the filtration. So we have the two forces which favor your filtration. So one force which favors the filtration. So I'm discussing the forces which favors the filtration. Favors. One force which favors the filtration will be your capillary hydrostatic pressure. Capillary hydrostatic pressure. Hydrostatic pressure. So means the pressure which is driving the filtration. Suppose capillary hydrostatic pressure is there. Suppose within the capillaries, my pressure is 30 mm. 30 mm of the mercury. And within the tissue space, my pressure is actually 10 mm. So it means there's a pressure difference of 10. There's a pressure difference of 10 which will drive the which will drive the fluid to move into your tissue space. So capillary hydrostatic pressure is the one which will actually favor the filtration, and second pressure which will actually favor the filtration will be what? Will be the osmotic pressure within the tissue space. When you have the increase, suppose if I have the increase, suppose if I have the, I would say with the black color, if I have the increased sodium, increased potassium, increased chloride within my within my tissue space, they will suck the fluid to come in. So can I say like this, other force which favor the filtration will be the oncotic pressure or osmotic pressure of the tissue space. Osmotic pressure, osmotic pressure of tissue space. Okay. All right. So these are the two forces which favor the filtration. Now there are two forces which is going to oppose the filtration. So I'm drawing this opposed filtration will be your color blue, opposed filtration. So two forces are there which are going to oppose the filtration, and obviously one force will be the plasma oncotic pressure. Plasma oncotic pressure means the oncotic pressure within the capillaries. And oncotic pressure in the capillaries depend upon your albumin concentration. Okay, because when your oncotic pressure or osmotic pressure in the capillaries is very high, it will not allow the fluid to go out. It will actually keep the fluid within the capillaries. So oncotic pressure, plasma oncotic pressure, that's a one force. Plasma oncotic pressure will not allow the filtration to happen. And can anybody tell me what's the second force which will actually oppose the filtration?
Hydrostatic pressure in the interstitium.
Excellent, very good. So when you get hydrostatic pressure in the interstitium, suppose my normal hydrostatic pressure in the interstitium is 10, and if it increases to 30, so they both become equal, there will be no net filtration. Okay, so hydrostatic pressure of the tissue space. Okay, hydrostatic pressure of tissue space. Tissue space. All right, so what is my purpose of defining these? What is my purpose of defining these filtration forces? Because there's a very common disease which is called edema. Now I'm going to discuss the edema with you guys. So that will be my black color with the edema. So edema is defined as an increased filtration. When you get increased filtration out of capillaries, which leads to increased fluid within the tissue space. So edema is actually defined as excess fluid within the interstitial space. Excess fluid, or I would say increase fluid within tissue space. So what could be the cause of the increased fluid? What are the causes? What could be the cause of the increased fluid coming into the tissue space? So number one cause could be your increased hydrostatic pressure in the capillaries. When I increase hydrostatic pressure in the capillaries, when I increase hydrostatic pressure in the capillaries, it will lead to more fluid coming out. Now, can anybody tell me what are the causes of increased hydrostatic pressure within the capillaries? Anyone?
Heart failure.
Very good, excellent. Heart failure could be there. So heart failure is actually there because it will lead to backward blood flow. Backward blood flow will be there. And you guys know that in the heart failure patient, you get what? Bilateral pitting edema. Bilateral pitting edema is actually seen in the heart failure. Okay. Heart failure. Very good. So that's a one cause. And what could be the other cause? Other cause could be when I have the decreased plasma oncotic pressure. Decreased plasma oncotic pressure. Okay. Decreased plasma oncotic pressure. Okay. So decreased plasma oncotic pressure will be seen when you have the decreased albumin in the body. Can anybody tell me?
Nephrotic syndrome.
Nephrotic syndrome.
Very good. What is nephrotic syndrome? What else?
Liver
Liver
cell.
failure.
Liver failure.
Liver problem.
Excellent. Liver failure where you don't produce the albumin. So it will lead to what? Pitting edema, is it? Why pitting edema? Because you only have the fluid within the interstitial space. There's not solute. when you get the solutes, when you get the increased solutes in the interstitial space, that will lead to non-pitting edema. So here you will get what? Pitting edema will be seen. Now, what could be the other cause of your, can anybody tell me what could be the other cause of the edema? So we change these two forces. What?
Kwashiorkor, malnutrition disease like kwashiorkor.
When I increase the oncotic pressure in the tissue space, is it? So if I increase the oncotic pressure in the tissue space, oncotic pressure,
Okay.
it makes sense because when you increase oncotic pressure in the tissue space, it will also lead to your edema. So you will get edema when you increase the oncotic pressure in the tissue space. And do you know what is the cause of the increased oncotic pressure in the tissue space?
There's a blockage in the
Blockage in very good what?
Lymphatic
in the
obstruction.
Lymphatic.
Lymphatic.
Very good because
lymphatic. Yeah.
normally what happens? Your solutes are cleared from the interstitial space by the lymphatic blood vessels. Once you block the lymphatic blood vessels, the sodium, chlorides, potassium, and other solutes will accumulate within your tissue space. So they will suck the water, and this is called lymphedema. Now, lymphedema will be what? It will be pitting or non-pitting edema.
Non-pitting.
Very good, because it is very difficult to form a pit within your fibrous tissue. It's very difficult to form a pit within the fibrous tissue. So that's why lymphedema is going to be your non-pitting edema. Okay, it's a non-pitting edema. And can anybody tell me what's the cause of lymphedema?
Elephantiasis.
Elephantiasis, very good. Elephantiasis actually there because it will, and it's caused by one of the bug. What's the name of that bug?
Buccaria bankrupted.
Wucheria
Wucheria.
bancrofti. Excellent. Wucheria bancrofti is actually the cause. Okay. Now, third cause of the edema, which we get when you get the changes in the capillary permeability. Changes in the capillary permeability will allow the fluid to come out. We get the edema in the infections as well. That's because of changes in the capillary permeability. So, what are the causes of the changes in the capillary permeability?
Toxins.
Toxins, like example.
Infection.
Give me the example. Snake venom toxin, infections, burns, they can also lead to the edema.
Sepsis.
Okay, so that was actually important to understand, and that's all about your physiology. And tomorrow we do our pathology. Anybody have any question regarding these forces and the edema? Everything good? All good?
Sir, I have a question.
Yeah, sure.
Sir, from pulmonary capillary blood pressure, there is an exception that in the pulmonary vein, the pressure is greater than the right ventricle. So what's the reason for that?
For the pulmonary vein? Yes?
In pulmonary vein, the pressure is 25/8, while
Yeah.
in the right
The-
ventricle, the pressure is
Yeah.
25 and the
Yeah, good
diastolic is
question.
less than 5.
Good question. Good question. So why the pulmonary vein have pulmonary artery, not pulmonary vein, okay? So pulmonary artery pressure is actually 25/8 because it have to send the blood into your pulmonary vein. Is it? Pulmonary vein, and it also have to overcome the lungs. In the middle, we have the lungs, so lungs have the pressure. Alveoli do have the pressure. So in order to overcome that alveolar pressure, its pressure is always greater than the right ventricular pressure. Get it? Okay.
Yes, sir. Yes, sir. Appreciate it.
Okay.
Doctor, I have a question here. So
Yeah.
when we talk about pitting edema, we said you talk about increase in oncotic. No, not oncotic. In the other pressure. It's not the oncotic. The hydrostatic pressure. So that case, when it's a heart failure, it has to be high output heart failure, correct?
No, it could be a systolic heart.
Because if it's a low cardiac output,
No.
usually you see higher pressure, higher
No.
pressure in the pulmonary, in the capillary of the lungs. You're gonna
Yeah,
see
good.
crackles in the lungs, correct?
Good question, but you have to think on the both sides. Think about the both sides. So when you get systolic heart failure, what will happen? The blood will accumulate within the veins. Is it? The blood will be going where? Blood will be going in the backward direction in this way. So it will be going into the veins. The blood will accumulate within the veins, and if your blood accumulates within the vein, it will automatically increase the pressure in the capillaries. So any kind of the heart failure, either systolic heart failure or high output heart failure, that will always lead to the pulmonary edema. Okay? Sorry, your pitting edema, because of the backward movement of the blood flow. Because when you get systolic heart failure, you get raised JVP, you get the peripheral pitting edemas. That's because of the blood accumulating within the veins. And once you accumulate the blood within the veins, it will go back to the capillaries. And once your blood increases in the capillaries, it will increase the capillary hydrostatic pressure. Okay, get it?
Thank you, sir.
Okay, all right. I see you guys tomorrow. Bye bye. Take care. Have a good day.